Okay, we are recording. Good. Screen good?
Yep, perfect.
We are ready. So, hello, everyone. We wanted to share today our second Zoom meeting and our webinar, and this is on recognizing common signs of school-age mental health needs, and then for our parents and community members, how to access them. And today, I'm fortunate enough to say I'm joined by Miss Vicki Reckenkamp, and she is the Director of Behavioral Health from Chop Tank Community Health Systems. And the director who also oversees our school-based mental health staff from her agency that comes into our schools. And I'm Dr. Rob Schmidt with Talbot County Public Schools and serve as the Mental Health Coordinator since 2000. So we're going to go ahead and share this with our families, and we're going to talk about this in a discussion and review some of the most important things that what we see, then how we can help identify some of the students that may be in need, unknown to the parents, so we can share with the parents any sort of concerns that we have. I remember working in the early 2000s. I had a chance to meet in a community meeting with Dr. Patricia Crowther. She is a former medical director for the world-renowned Philadelphia Child Guidance Clinic in downtown Philadelphia. And, she had done several publications, some research that was actually not published. And she shared all of her research with me. And, one of the important things that stuck out during that time when we're working with, our children in school, typically ages 3 or age 4 through 19 to 20, she said that despite I'm sorry, let me slow down a little bit. Despite an inherent ability to learn, children are not benefiting from a regular teaching or classroom experience, as shown by their continued academic underachievement. And this was due because there are so many barriers that exist that impact learning. And that kind of reminded me of the research that's done or was done through Drs. Adelman and Taylor from the UCLA School Mental Health Project, which also grew at about the same time, just before 2000. And in their research, they found that, only 10% of any given classroom. So right now, the average classroom in the United States is about 25. So if you look at only 10% of that classroom, so you're looking at 2.5 children, really not a half child. So it's either 2 or 3 students in that classroom are ready to learn with what the teacher's prepared to teach. So then the question is, and Vicki is here, she's also an expert in this, where are the other 23 kids, 22 kids in the classroom? And, some of those barriers that are interfering or impeding a child's ability to learn, it's just infinite. There are so many different things that affect us. And I'm going to share just some recent statistics in the United States as it relates to the school age population. In the United States, and this is related to the most, and Vicki, you can add anytime, the most well-known school age diagnosis.
Back to your last slide, a large thing that gets in the way of that learning is poor social emotional development. And a lot of the mental health disabilities that we're going to talk about today often lead to children to not be where they should be socially and emotionally at a specific age. And when your emotions aren't in place, learning doesn't happen.
Right. And we got to figure out where those emotions are. Like, where are they rooted? Like, why not? Like, why are these things existing? Like, why? So what we do know is that in the United States, 20% or 1 in 6 children between the ages of 3 and 17 have some form of behavioral or emotional symptoms that can be diagnosable during the course of a school year. It used to be between 10 and 22%. So I think 20 is a pretty solid number. The most common symptoms associated with ADHD, attention deficit hyperactivity, 9.8% of that population in the United States, which is about 6 million school-age children. Behavioral health problems or behavioral problems, 8.9%, which is about 5.5 million school-age kids. And then depression or depressive type symptoms, which 4.4%, which is 2.5 of I mean, 2.7 million school-age children. And then when you look at anxiety, and I think since this data was done, we are looking, this is from the Center for Disease Control, we are looking at higher numbers of anxiety. So I'm thinking that because of the pandemic, that we're seeing higher rates in our schools related to anxiety, foremost when it used to be depression and then anxiety. Vicky, I don't know if you're seeing any of that also, or?
Absolutely. I would say of our pediatric population, that are in therapy or being referred to therapy or not, or neither of those, just through feedback from our pediatrician, the increase in anxiety is exponential. Even in our adult population of patients that we, with the pandemic, this is going to be a residual fallout of the pandemic for quite some time. And a big part of that anxiety is around social anxiety, right? So we had little biddies who never started school until first grade, and they were home all that time, and they were living off their parents' anxiety of the pandemic. And now we're in school, and what I'm seeing with teachers is there's behavior in first grade that isn't typical behavior probably that you were seeing in preschool, but now we're seeing it in first grade, and it's difficult for the teachers to maneuver, right? It's hard to teach when you're dealing with those kinds of behaviors.
Yeah, and that's a good point. Yeah, definitely seen it like below when we didn't really see exhibited behavior related to anxiety was a little bit older and later elementary school, middle school especially. But we are seeing it much younger. Exactly right. Thanks for bringing that point up. Yeah, and to see someone that is 5, 6 years old, right, exhibiting symptoms at the earliest grades, it's like, wow. Where is this coming from? What's the interpretation of the world that they are living in and that we can help out with, right?
Yep.
So, because there's so many adult pressures and trying to process the world around us that the behavior has got to come out. So, so what we're seeing also nationally is behavioral, mental, and developmental disorders, initially appearing in early childhood for ages or between the ages of 2 and 8, which is 1 in 6. And if you think about this, kind of goes on what we're just talking about here. That's 17.4% of the population for that age group in the United States. That's a significant number, right? And adolescence, depression, substance use, suicidal thoughts and behaviors we're seeing commonly occur. 3 out of 4 children showing signs related to depression, but they also have anxiety in addition to that. So it kind of goes back to what we talked about earlier.
Yeah.
Did you have something to add? I'm sorry.
I was thinking about that, that combination of anxiety and depression, and we'll talk about it a little more later, but those are those kids that we're seeing that are now being diagnosed with complex childhood trauma, right? So you're seeing both the depression and the anxiety. And that, behavioral problems in elementary school, especially, anxiety and behavioral problems go hand in hand because the biggest piece of anxiety is dysregulation, right? Especially in little kids.
Yeah.
So, they all kind of play together. But those numbers are very significant. And I would, like you said, imagine they're even higher now.
Yeah, exactly. Yep. So, and they're usually brother sister type of diagnoses, anxiety and depression in our middle and high school students, especially, and the ones that are identified. So, children with anxiety, which is 1 in 3, also had depression, and then children with behavioral problems, 1 in 3 also had anxiety, and 1 in 5 also had depression. So, what was an interesting statistic that I covered, and looking at like how do adults, like we have diagnosing as adults, of course, and diagnosable disorders, or I like to use the word probably something instead of disorders, just some roadblocks or ways to work through life. What we found, like, how do we get to that point? And, research suggests that 50% of all adult mental health disorders, which is quite a lot, began showing or first showing signs by the age of 6 for anxiety, which is what we just talked about. By age 11 for behavioral disorders, by age 13 for mood disorders like depressive disorders, and by 15 for substance use. So if we look at all of the adult mental health disorders, could it have even got to that point if they would have been identified much earlier and had some things, situational kind of things resolved before it rooted or, increased in the symptoms so that when they became adults, it really could not be controlled personally anymore. And so the seeking help or medication greatly increased. And Vicky, seeing that with our kids now, or what's the importance of identifying early?
Because the earlier these issues can be diagnosed, the sooner we can get them into therapy, right? And a lot of this can be stopped. I'm looking at the by 15 for substance abuse. Substance abuse is a symptom of all those other things, right? So what we're seeing is, these are kids that are going through life undiagnosed, not knowing how to deal with the feelings that they're having, and that substance use helps deal with those feelings, right? So it numbs. It's a good number, and it becomes my coping skill, maladaptive coping skill, but it becomes my coping skill because I don't know what to do with all those other feelings, and we will see these disorders in children who also have parents who are struggling emotionally, right? And so, if I'm an adult struggling emotionally, I have a really hard time seeing that and recognizing it in my child. So school plays a big role in that. And I say that all the time, oops, what happened? Yikes. Where did we go?
We lost our internet connection. So let me do this again. What the heck? Give me a second.
Well, that beginning part's probably recorded. You can splice.
Now we're good. We're good. So let me get rid of this and redo this. I don't know what happened with the internet in Easton here. That was okay. So let me bring this out. I'm going to hit record. Where is, okay, recording is good. Screen share. We lost our internet in Easton and we had a minor pause right quick. Yeah. So we're picking this back up because Vicky, you were sharing about, when we're talking about adults having disorders and how the importance of students at younger age being picked up or identified so they get the help they need.
And it's important because we can prevent a lot of adult problems if we catch them early. Dysregulation is a big piece of all of these disorders, which really impact us as we go through life, right? If we can't regulate our emotions, we're going to find ourselves in places that we don't want to be, right? And in confrontations that we don't want to have. Substance abuse, as I was saying, is a big self-medication for a lot of people with mental health disabilities, right? They self-medicate when they don't know what to do with those emotions. We can prevent that in our adolescents. We can prevent that in our adults if we can help them work with those symptoms early on. And as I was saying, if a parent doesn't know how to regulate emotions, they can't teach their children how to regulate emotions. And they're not going to probably identify that their children have a problem, because it looks very normal to them. Mm-hmm. Schools are going to play a big role in that if we can catch it in school and we can identify it and refer to treatment while the child is in school, we can help stop stuff from progressing as the child ages.
Exactly, because developmentally, what we're doing is when we're dealing with initial problems or concerns or perceptions of problems, we're developing coping skills at a young age, and they can be guided with the early identification with developing appropriate coping skills, which we all have. But I agree with you, because if they do go unchecked, then what's going to happen is we're going to figure this out by ourselves, and they may not be always the most appropriate coping skills. So it may be reaching out, risk-taking for increased risk-taking behavior, drugs or alcohol, or doing other things. I don't know. So, if we can help guide and steer in the direction of what to do if you feel like this at an early age, by the time kids get to be adults or young adults or go off to college or work, they could, at least have some sense of moral decision making of what is right, what is wrong.
Yep.
Because we all have problems. Exactly right. Yep. So I'll move on to the next slide. So this is by age. Really important to see the differences here across the different, like, elementary, kind of middle, and then high school ages, of course, dealing specifically with depression, anxiety, and behavioral disorders. So you have these disorders by age. So you can see ages 3 to 5, how that increases with behavioral problems versus, anxiety or depression in a young, within that same age group. And then you're looking at, ages 6, which is first through probably 6th grade, 5th grade. In that age range, you could see also behavioral problems and anxiety, what we talked about, also greatly increased. And then when it gets to the depression, when you're looking at the ages of 12 and 17, depression is starting to rear in there, and then anxiety is really increased. And then you look at national statistics right now with behavioral problems. So, these are the age groupings the Center for Disease Control identifies through their national screenings and YRBSs. And so if we're looking at any of these symptoms related within these age categories, I mean, having school-based services or professionals contracted in to come into the schools offers a wide variety, but also, Vicki, it shares the importance of our school counselors and their identification, because what we see in schools is that, especially younger grades, middle school especially, is that all of a sudden we see a drop in grades. We see loss of interest. We see fighting. We see withdrawal, tearfulness, and we see kids that, when they're put a test is maybe placed in front of them, all of a sudden, I can't think, I'm tapping, I'm biting my nails. I'm like, get me out of here, because I don't know what to do with all of this. I feel like I'm going to fail, but I'm prepared, but I'm going to fail. So the anxiety piece. So what are your thoughts related to these kinds of things?
So, I mean, again, right, seeing these numbers are important, I think, for um, professionals to kind of plan, grades that might be more needing of services. Um, but that anxiety in 12 to 17-year-olds makes sense, right? We're getting more things to cause that anxiety by that age. We're seeing the behavioral symptoms go down in 12 to 17. But again, there are probably now those kids who were 6 to 11 with behavior problems are now using those risk-taking behaviors to kind of help with some of those feelings, right? So again, I think these numbers are probably even higher thanks to the pandemic. But what I've always said to teachers is that, in school systems is, our children are in school more than they're not. And so we really have the opportunity in schools to make a lot of change. If a child feels safe in school and heard and understood, we can work with a lot of these problems. But if they're living in upended home lives and then coming to school and feeling that same kind of unsafety, things aren't going to progress and get better. Resiliency happens when there's an adult. It doesn't have to be a parent, an adult in a child's life that is their support, and we can provide that in schools, which is a wonderful thing.
Yep, exactly. Yep. And, and when you look at depression and anxiety and behavioral disorders, I mean, there are definitely some known in literature, differences between how school age boys and girls represent, in most cases, not all, but represent or exhibit their symptoms or show their symptoms. And what we see is boys seem to be more externalizing, more argumentative, more physical. And with girls, we see more of a withdrawal, maybe tearfulness, kind of like pulling back, kind of like melting inside and trying to figure out what to do with these emotions. And boys are like just the opposite. And typically that's how a lot of our students, around the nation actually, and in our district also, the teachers are great because they can notice these changes and subtle differences in behaviors because they are with the student during the course of the day quite often. So.
Exactly.
Okay, we'll go to the next. Anxiety, did you want to take care of this one or you want me to do this?
I can take it if you want. So, anxiety, and we've been talking about a lot. I think one of the things for parents and teachers to understand is that anxiety can happen at any age. It's not limited to teenagers and adults. Sad part now, with thanks to the pandemic, I think we're seeing it younger and younger. One of the things we have to do be careful of with anxiety can often look like ADHD, right? So we have the same kind of symptoms, fidgetiness, um, worrying, anger, outbursts. The thing that looks the same is, hyperactivity in ADHD can actually be hypervigilance and anxiety. So it's just a child that's kind of always on the edge and looking out for what's coming next. You know, Attention in ADHD can really just be perseverative thoughts in children, right? So I'm attending, but I'm not really here in the room with you because in my head is really, I'm playing that reel of all the things I have to worry about today. And I have a really hard time shutting it off. And little kids, we're going to see a lot of somatic problems. So stomach aches, headaches, crying, easily startled, distractible, because they're going to hear all noises around them and they're going to focus on those noises and not necessarily on what's going on in the classroom. Anxiety comes from all kinds of stuff, right? So we can be born with anxiety. We can be born with a predisposition to anxiety. Children growing up in households with anxious parents tend to become anxious children. As children, we learn how to regulate our bodies by our parents, right? And like I said earlier, if my parents have anxiety and they have a hard time with emotion regulation, I'm going to learn that from them. I'm going to also get that sense that the world is not a safe place because my mom is worried about it every day, right? And a child relies on that parent for that comfort, support, and feeling safe. And if I'm not getting that, if I'm not picking that up in my household, then I'm going to be anxious as well. As we grow, there are other things that happen in our lives that lead to that anxiety. But there is good anxiety and there's bad anxiety. So everybody has some sense of anxiety. We use that to plan what we need to do and move on in a project. It gives us that push that we need. But once we get to that project, that feeling usually resolves. For somebody who's really struggling with clinical anxiety, those problems never resolve, right? So I'm panicking to get to that thing, but even once I'm in that thing, I can't let that anxiety go. I'm going to still have those thoughts. When I do a speech, I'm anxious up to that day. When I'm doing it, I'm not. When it's afterwards, I feel great, right? So, but that's normal anxiety. If I was struggling with clinical anxiety, I would keep perseverating about this and thinking about this for the next week and a half. I wouldn't be able to relax. I wouldn't be able to settle. And that's something to look for in children, right? A little bit of anxiety that goes away quickly is not something to worry about. But if that child struggles with it every day, all day, to the extent that it's making them physically ill, or they don't want to go to school, don't want to leave the house, that's something that we really need to think about. Some of the causes are listed on there, and you can see at the end it says traumatic events. And parents need to know a traumatic event doesn't have to be physical abuse, sexual abuse. It doesn't have to be a house fire. It can be any experience as a child that is out of the norm. So divorce of a parent, death of a loved one, frequent moves, maybe bullying in school. Those are all traumatic events that can lead a child and a grown-up to have some anxiety. So, pandemic was a real big one, right? That was an acute stressor that nobody was planning for, which led a lot of people.
Yeah, life altering, literally.
It was an acute trauma, right? It was bad, and it was in the moment. For people that didn't struggle with other things, maybe that's resolved for them already, but for others that have had other traumatic events in their life, that pandemic just made things even worse.
Yeah. So we're going to behavioral problems. I'll take this one. So temper tantrums, power struggles, oppositionality. I think in our next November webinar, I think we're going to be covering about the, setting for parents how to help assist and guide towards setting rules and limits. So we got power struggles, and that's included in that. Will be included in that in November. And we're looking at oppositionality, oppositional type behaviors, refusing to follow rules and challenging behaviors, refuse to obey parents, authority figures, lack of empathy, aggressiveness, lying, refusing responsibility, or taking ownership of maybe a bad choice, run away, stealing, fighting, vandalism, breaking things or breaking into things, playing with fire, argumentative. So behavior problems, they could be just about anything that will be out of the norm, purposefully done in most cases. Very few cases, something may happen where I'm not aware of it, and I do things, understandably so, given what the behavior is or the history of that individual may be. And looking at some causes, it could be developmental regressive types of behaviors or reactions where I'm maybe stuck developmentally at an age, even though chronologically I am, 15 years old, but then I get into these regressive type behaviors that are more so rooted in temper tantrums, much like a younger age child would be. Any sort of family turmoil, dysfunctional family in turmoil. I think, Vicki, you talked about, divorce and separation, which is probably the chief cause of most of our school counseling or mental health referrals are related to family types of problems, which we all have, of course. But when it gets into divorce and separation, typically what we see is the children absorb everything that's going on in the home, and school is always typically the safest place to vent or let things out, emotions, because it's safe. Poverty. Did you have something? Okay. Domestic violence, poor parenting skills, or substance use in the home. Any sort of, like Vicki also talked about, traumatic events or experiencing or witnessing or observing or hearing noises or sounds or visually watching something happen, unfold. And then, overall, the inability to regulate my emotions or moods. And all of these, usually with behavior problems, our behaviors are rooted in purposeful interactions or thoughts. So most of our behavior is purposeful or motive oriented or driven because there's a purpose for what we're doing. And very rarely we're not really tuned into what that may be, but most cases, kids, adults in general also know what they're doing and what the purpose of that is.
And if I could add a little bit,
yeah.
It's not purposeful in that a child's doing it to be bad, right? So,
Right.
Dysregulation causes chemical reactions in our body, and it throws us into fight or flight. So we are trying to reach an end with our behavior. Sometimes it can be unconscious, right? So we've learned through reinforcement how to get a need met in a maladaptive way. And this starts young. So if we're dysregulated or don't know how to express ourselves properly, but when we throw a rock at the wall or at the window, and then all of a sudden we get all this attention for that behavior, even though it's somebody yelling at me, I learn at a young age that if I need your attention, this is what I need to do to get that attention. Unless we catch that early, that continues to be reinforced over time, and a child learns that this is how I get that need met, right? And so it's really important for us, again, to catch it young. A lot of this dysregulation problem happens before the age of 6. And as adults, we're in charge of teaching children how to regulate their emotions. So if we don't catch it early, it gets very maladaptive over time. And then that's when you see a lot of that conduct disorder problem in adolescence. And some of that acting out can be very dangerous for others and for that child.
Yeah. So it can go back also to developing inappropriate coping skills, thinking this is the right way to handle my problems, but it's really not. That's why the safeguards provided by adults really assist along the way. ADHD, what does that even look like? Attention deficit hyperactivity. I do have to say it's probably one of the most overdiagnosed mental health disorders as they identify, as the DSM-5 identifies, because it's rooted on, and most diagnoses actually rooted in subjective perceptions of what the problem is, shared either by the parents or by the older adult or young adult or student. So what does this look like? I mean, it typically appears some as young as 5, few instances as young as 3. And typically what adds some credibility to the diagnosis is if a Connor scale was done or completed or offered by the pediatrician or mental health practitioner, or the Vanderbilt scales offered and helping to collect data and information that would relate to that, because it might be something else related to maybe anxiety. Vicki said, you said earlier that, anxiety can be looking like ADHD, right? Where I just feel.
Yeah, so many of our mental health diagnoses, right?
Yeah.
They all cross over. There is no blood test, so it,
That's right.
like you said, much of it is subjective. And so having a clear social history of that child before a diagnosis is made is really important. What I say to parents is, we know it's ADHD when it happens everywhere, and that child cannot control themselves, right? So a child with ADHD, even when they're trying their hardest to attend and sit still, something will be moving on that little guy's body, right? So a leg will be jiggling, a hand will be moving, a pencil will be tapping. It's really out of their control, ADHD, and so that tends to be, if it's happening in all domains, that's when we think, it may be more ADHD than something else.
Right. So symptoms associated with ADHD: persistent problems in paying attention, focusing, concentrating, hyperactivity, completing assignments or tasks, organizing. If you look in your child's book bag, sometimes it can be at a younger age, just being a boy. It just, sometimes we're a little bit wired differently and we just throw things in. And we just need help organizing. But if it's something I'm getting help with and I'm still not able to organize, then we have to look at maybe some other things. Losing items in the desk or book bag or backpack, easily distracted, forgets, looking at behaviors, possibly. Am I interfering with other kids or distracting other kids? Am I, I'm hitting people? Am I reaching out to people? Symptoms can vary from mild, moderate to severe, and age typically does play a role. As someone gets older with some of the symptoms, not in all cases, but in a lot of cases, it does seem to diminish more intense symptoms as we get older naturally. But it's, right now, the question is, at a young age, being in school, is this impacting my daily functioning, which means I'm not able to learn because of my ADHD. I just can't get this information in. I don't remember it. I can't get it out also. Further classifications: predominantly inattentive, predominantly hyperactive, impulsive, and combined, which means it's including, all of the above. So I'm not only physically acting out, I can't control it, I'm also can't pay attention on top of it. So how much learning am I going to get during the course of a day, right? It's very difficult. Causes: deficits in the front part of our brain, the frontal lobe. Could be genetic, hereditary, related to ADHD, running in the family. 1 in 4 students has a parent with ADHD that has been diagnosed with ADHD. Significant possibly experiencing a significant traumatic brain injury, prematurity, prenatal exposures to drugs or alcohol, any sort of environmental toxins, specific to like lead, could definitely impact that. And I know, Vicki, you touched on the myths of this, and what does that look like?
So what parents need to know, and it was a very popular thought when I was a young child, there is no evidence that eating sugar, uh, foods that have additives, color dyes, allergies, immunizations cause it. ADHD children are born with, right? It is a deficit in the frontal lobe. So they're born that way, and a traumatic brain injury can cause those frontal lobe deficits, right? So The sugar is could cause hyperactive behavior because you're getting a glucose rush and then you're crashing, but it's not going to cause ADHD. Immunizations, there's been no medical research that proves that immunizations cause ADHD or autism spectrum disorder. So,
And I have a question real quick. So say I have 4 classes during the course of a day. Can I only have ADHD during my math class?
you cannot. ADHD, and that's really so important for parents to know, right? So if I have ADHD, I can't control it wherever I am. Now, kids with ADHD can hyperfocus on things that they really, really love, which I think is often confusing for parents, right? So I could be bouncing off the wall over here with something I'm not interested in, but if you give me a video game, I can be affixed to that for 14 hours in the day, right? It, 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 it's it's all about the brain, right? And once I'm perseverating on a topic, it's hard for me to pull away. And then when I'm not connected, it's hard for me to connect. ADHD's big issue is time management and impulsivity, right? And it's very hard for them
And
often to put short-term memory into long-term memory because of that brain development issue.
and
And they don't learn from their mistakes, I guess is what I'm trying to say.
And Vicky, you used the word hypervigilance. It kind of reminded me of a book I read a long time ago. It was written by Dr. William Glasser, and he wrote the book it's called Positive Addiction. And I know we think, oh, ADHD, I think that's a great gift. It's channeled in the right direction. Hypervigilance, and you look at some incredibly successful people, and they would not have been successful if they didn't have ADHD, if they weren't able to channel and become immersed in that study or whatever they did, or in the invention or whatever they did, running a business or, being a chef. I mean, if they didn't have ADHD, probably wouldn't have been as successful, because I think it is a gift if it is channeled in the right direction, where I do become a live, sleep, eat, and breathe it. And some athletes are also like that also, because they always prepare for perfection and success. And with some failures involved, they overcome it. They just stay focused. It's,
really about finding somebody that can help you learn
help exactly that pathway.
with the deficits that you have. Medication can help in some cases, but not in all cases, right? And so
Right.
really connecting with a therapist or a psychologist that really knows how to work on behavior management skills can really help a child with ADHD. They can do it. They need a roadmap where maybe the rest of us don't need that roadmap. But once they have
Rodent perfect. Yep. Right. Did you want to go ahead into depression and depressive type symptoms and what that looks like?
depression, depression is tricky because depression looks different in different people, right? So little kid depression between, well, and I hate to say it, but I've met children as young as 3 who have some severe depression, from 3 to 10 maybe. That depression is going to come out more in behavioral things. So we're going to see this behavioral dysregulation in little children with depression, because they have those feelings, but they don't know what to do with those feelings. So a lot of acting out in young children could actually be depression. We're going to, as we get older, depression usually manifests in kind of caring less about things, sleeping more, withdrawing from things you once loved. Boys, as you talked about earlier, will continue to have more of that acting out behavior. Girls tend to implode, not explode, right? And so girls will be they're typically more withdrawn when they have depression. That's the quiet kid in the back of the room that's never bothering anybody, but never really engages with anybody either. We see concentration. Well, alcohol and drug use, because again, let's go back to what I said earlier, right? I'm self-medicating. I don't like feeling this way. I don't like the thoughts that I'm having. If I'm high or drunk, those feelings go away. If I'm having trouble sleeping at night, if I am drunk and pass out, It helps me with my sleeping. We have, again, increased physical and somatic complaints, a lot of stomach ache, achy joints, headaches, um, tired all the time. You know, you have a kid that was very, you know, external and doing things all the time and making friends and going out and being a part of school sports, and then all of a sudden they don't even want to leave the house. That's a concern, you know. Suicidal thoughts are there. Girls can be a little more verbal about those feelings, and when you hear your child talking about that feeling, don't blow it off. Listen to them. Um, Sadly, boys do not speak about those feelings. They have them, but they don't share them until it's too late, right? So, um, again, keeping an eye on these symptoms, especially that pulling away from things. Um, Child who used to always be down in the living with you watching TV and talking, who now comes home and locks themselves in their bedroom every night, that's a concern. Some of that is teenager. You know, the other day, and it's not having a teenager like owning a cat. They hide and come out and hiss at you and then go away again. That is a teenage. So some of that can be teenage years, but when it's extreme, that's when we need to look at that. There's all kinds of causes for depression,
Causes, yeah.
you know, and for some people, although I think it's fewer than most, for some people, depression is clinical, which means it is a brain issue, right? So it's non-production of serotonin and dopamine, and so medication does help. But for most people, I think depression is situational, and
Situation, yeah.
and it gets bad over time because when you're depressed, you see everything through a depressed lens. So, you know, the longer that feeling lasts, sadness lasts, the longer you feel like this is not a life worth living, right? And you start to focus really every day on all the negatives and not the positives, because that's how your brain starts to process things. So situational events, death of a loved one, in adolescence. Sometimes it's even disruption in a relationship. Um, you know, remember, teenagers can be involved in domestic violence situations as well. That doesn't just happen to married couples or adults, right? So I have worked with many teens over the years that are in very domestically violent um, high school relationships, especially emotionally. And so you want to keep an eyeball on that too. If they're in a relationship that you're feeling as a parent isn't going in the right direction, it's a conversation to have with your child. Family problems, again, divorce, um, financial, and families are going through financial situations. We lose our home, we're, you know, homeless, or dad loses his job and we're really, really struggling. Mom's been home all the time and now
Mm.
mom has 3 jobs, right? So those are family problems that
Yeah.
are not in any way purposeful by a parent that are happening in life. Extreme physical illness, chronic illness can cause depression easily. Um, any kind of stressful life event. But the biological component, like we were saying, it's there. But for most people, depression is going to be situational, you know, and for some, it's situational that lasts over time. And it's very hard to get out. If medication will work, it'll take the edge off. But really, truly, especially for situational depression, therapy is key.
Great. Yeah, great. Yeah, and we talk about, the physical and somatic complaints. Most of our wellness centers are school-based nurses. Visits during the course of a year, over 60% related to these somatic complaints where they have feelings of maybe stomach aches, headaches, but they're unfounded. Because of the stress, anxiety, or depression roots itself in physical complaints without any sort of cause. So, and usually under stress and anxiety, our weakest organs give in. So we may have stomach aches. We don't know,
Well,
you
and
know?
the somatic complaints can actually become physical stuff, right? So we
Yeah.
know,
Yes, definitely. Yep.
you know, extreme anxiety and depression over long periods of time actually lead to real physical health issues.
Yep. Vicky, you brought up, I wanted to cover this, so I'm glad you brought that up in the last slide about the suicidal thoughts, because, where we are right now, we need to take this stuff serious, because the United States right now, we are in a child and adolescent mental health crisis mode, where we're seeing more children exhibit mental or show mental health symptoms than probably we ever have in the course of the history here. So, and every couple of years, actually 2 years, the Center for Disease Control does the Youth Risk Behavior Surveillance System. It's a survey that's given out to middle and high school students. Every 2 years, it covers about 16 to 20,000 students across the United States, and Maryland was one of those states that participated. And they look at risk-taking behaviors across the past year, and it covers anything from drive with someone. You can look at it online, look on CDC YRBS results, and it'll give you those results. And it looks at like risk-taking behaviors that relate to driving with someone who's used alcohol, you used alcohol, drugs, of course, alcohol, driving, using your seatbelt, unprotected sex, being forced to have sex, depression, again, anxiety, and it covers all of those things related. And it also covers and has a section on there related to over the past year about suicidal thoughts. So it covers like, have you felt sad or hopeless almost every day for the last 2 weeks or more? And 42% of the respondents, which is pretty significant. If you think about this across the United States, these are not Maryland statistics, but national statistics. That's a lot. If you look at 22% seriously considered attempting suicide, that's 1 in 5 kids. Again, if you have a classroom of 25 kids, I mean, there you have it. That's a lot of kids. That's 5 kids in your classroom. That's like, what's happening here? Made a suicide plan, which is 1 in 6 students in a classroom of 25, which takes you up to be what, 3 or 4 kids? That's a lot. Made an actual suicide attempt. So there's about 2 kids in each classroom, presumably, according to national statistics, or 10% of your classroom that has made a suicide attempt over the past year. 1 in 40 students made a suicide attempt that actually required medical attention. We know we don't know, because a lot of times if the ER is not trained on picking these things up and is more presented more like an accident, then it's not going to be picked up that this was an actual attempt. So again, these numbers are way low here at the last one anyway. And presumably, if I didn't make an attempt, I'm going to be in school most often the next day. So these are really high, significant numbers. If you look at the trend data since 2011, nothing has gone down, and it's actually increased across the board. And again, we're injured in a suicide attempt that need to be treated by a doctor. I mean, that's stayed the same, but really, we really don't know because of the misclassifications of what that, of what that looks like of getting help. I could have said it was a fall. I don't know. So that's the thing about asking a lot of questions. Suicidal thoughts associated with depression, withdrawal, sadness, increased risk-taking behaviors, thinking about suicide. Key words associated with suicide is ambivalence. And the ambivalence factor is, I really want my pain to go away. I feel like there's no other way. So what usually typically happens is I'm starting to give clues away, typically 3 months in advance before the first actual attempt. And, the word kill myself is very rarely used, but I'm giving clues like, who would even notice if I'm here anymore? Maybe things would be better without me. All these innuendos, again, if you're not trained to pick these up or take serious, not minimize it. And we're seeing these actually from younger students. So we're seeing these in age populations below age 8 really increased over the last 5 years. And who would think first, second, third graders would be having these thoughts? Well, they are, and we're not minimizing them. We take everything that's said seriously, of course, because if we do not, the flip side of that is it's irreversible. So everything is taken serious, and we do everything to address that. Looking at sadness, talking about suicide or hurting themselves, clues, being irritable, feeling like I'm stuck and I'm in quicksand and I'm sinking and I have no way of getting help. So if you can imagine going through life at a young age or even as an adult without feeling hopeful. So in other words, you're in that hopeless spin, like there's no solution to my problem. Naturally, sometimes to think that I'm just going to take care of this once and for all. It's actually not natural. That's why we have to pick this stuff up. Because these are temporary thoughts that come and go. They increase and intensify if I'm giving you clues, and then I feel like nobody's picking these clues up. So really, my interpretation of that is that nobody really cares about what's going on. So suicidal behaviors, increased efforts to avoid the pain. Our two basic drives in life, they're to seek pleasure, which we all want to have fun and laugh and do things that makes us, or be around enjoyable people, enjoyable company, and doing enjoyable activities. And the second flip side of that is we want to avoid pain. And you got the physical pain. We can see that typically broken arm, leg, sprain, or headaches or anything like that. I mean, we could usually pick that up. We could see it visually, how it's affected you. But the psychological pain, I can mask that so well. I can put on the happy face. I can put my happy uniform on for an hour or two, but during the course of a day, it really is waning and it really does just show itself. So we can't take an x-ray, either whether it be at the ER and look at your psychological pain. We can't do that. The ambivalence, because I don't want to feel this way, I'm giving clues again. Ambivalence is a key word with suicide. Kind of goes back to the song, The Clash, Should I Stay or Should I Go Now? I really want to stay. I'm thinking about going, and I really wish I could find another way to stay. And that's the ambivalence. And so along those ways, because we are not born to kill ourselves, we give away clues to our people that are around us, or isolate and give clues just by our behaviors, because we talked about, Vicki and I talked about earlier, that most behavior is purposeful, right? We're sending messages. It's communication. It's paraverbal communication. Giving away prized possessions, searching for methods, maybe how to carry out a plan, maybe planning it. Again, maybe risk-taking behaviors are increased also in the later grades with substance quiuse. Don't care attitude, don't care about anything anymore. I really don't care what happens to me. Nothing's ever going to change. Again, it's that spiral downward in the quicksand called the suicide continuum. Verbal or nonverbal threats, again, related to that. And, the causes, it could be, in literature, the genetic linkage of a family member that has passed, family problems, stress, family history of suicide attempts, aggression, disruptive behavior, bullying, hopelessness or helplessness, and a sense of loss. Again, Vicki may be fine if she gets dumped by her boyfriend. I get dumped by my girlfriend, that might be it. That might be the last person I felt that loved me, and sometimes younger ages, which means school age, will threaten that when they see their mom and dad going through a separation or a divorce. And they may use that, feeling like in my mind, I'm going to that's a way to get mom and dad back together, using me to get mom and dad back. Or if I lose my mom, my mom dies, she has cancer, or my dad gets in a car wreck or has a heart attack. Sometimes, or if I'm a younger child and my pet dies and I want to be with them, and that's understandably so. And that's working through that and having someone to talk to about that. So, and Vicki, I didn't know if you had anything to add in addition to that.
Said about the ambivalence, Rob, it really brought a thought to my mind. So, children could be suicidal, having a suicidal intent, and you not catch it, like you were talking about, because there is such a thing as passive suicide, right? I wouldn't consciously go out and kill myself because I can't go there. But I'll drive my car really fast because I might die. I'll use drugs because I might overdose. So I'll walk across the street and not really look and see if cars are coming. If I die, I don't care, is really where that feeling.
If it's meant to be, right. I heard that before many times, actually.
This person I don't want to make sad or hurt. But if it happened to me, it would be no big deal, right? And so we got to really look at kids who are sending that message to us, like, yeah, I know it's dangerous, but who cares? So that's a concern, right? That's something we got to hear in that child and pay attention to. as a parent of 3 children, I am going to say never, ever not listen to your child if they say they're sad, right? That that's somebody looking for help. And what it starts with is I say, I'm feeling sad. As a parent, maybe I go, oh, what do you got to be sad about?
You'll be
You
all
know,
right.
there are 27 other boys will come along. And
That's right.
we don't mean ill by it, but our adult brain says these are not things to be sad and depressed about, right? And so we kind of blow it off. And we blow it off again and we blow it off again. And then we get to that place where our child's saying, I just want to die, right? And then I stop everything and I go, oh my goodness, like we got to take care of this. She's suicidal. I don't want this to continue. That saying that I want to hurt myself becomes, again, it's a reinforced behavior. It becomes the way I now say to you, I'm sad because I know you won't pay attention when I'm sad.
Right. Yeah.
I say I'm going to die, everybody's going to listen to me, right? So the message there is when a child is sad, a child is sad. What do you got to cry about? Stop crying. If I'm crying, I have something to cry about. It may not be something worth crying to
To
you.
you. Right, right.
To me, it's worth crying about. So I guess what I'm saying is never blow off an emotion your child is having. Take it seriously. Take 5 minutes to sit with them and listen to it. Because that's how we help our child regulate. That's how we help our child know that in a crisis, I have somebody to go to. And I don't have to take this next step.
No, exactly. And talking about, being sad or that really hurts me, and then if you don't take that serious as an adult or as a parent, before I get to the point of saying that I want to hurt myself, I'm showing signs before that because I'm starting to pull back from you because you really, you don't care. So maybe self-isolating in my room, maybe I'm decreased eating. I don't want to be around you. I don't want to be around anyone. So I'm more time on my phone, with social media, which is probably not great in those times, if at any time without supervision. But yes, we got to take it serious.
Here's a whole other training.
It's actually coming up December 21st. We're going to be talking about the pros and cons and the warnings of social media. So that's going to be a webinar on the 21st of December at 2:30. So again, very important information shared. I just want to make sure, Vicki and I get this out to you that, anytime that your child is, you see or noticeable changes in their behavior or pulling back or not being around for dinner, like just changes. And they don't have to be abrupt changes. They really start off as subtle changes. And then Vicki, thank you for being on here because, and you said about, adult brain, like if our child's going through something like we lived through it, you're going to be okay. We typically know the outcome, but at the time for that child, it's traumatic. It's the end of the world, And actually, we in some of our research, we've seen like in 12th grade, the number one reason for 12th graders in general having suicidal thoughts was related to boyfriend-girlfriend breakups. So it is serious, and we need to take time. I think the CDC also had a saying back in the early 2000s, take time to talk, make time to listen. So take 15 minutes a day with your child, typically over dinner was a great, with no social media, no phones, shut things off, shut the TV off. Let's be together. Let's talk about how your day is, what's going on. Let's be a little bit intrusive. Being a parent is hard, but we have to spend time, quality time, with the kids to learn about what's going on. So, Vicki, did you have any last?
Yeah, well, what you just said, right? It's quality time is not quantity time. Because I know as a working parent, life gets stressful and it's really hard to think about just stopping what you're doing and finding, I don't have an hour to spend with my kid, right? Everybody has 10 minutes, right? Even if it's when you're tucking that child into bed at night, or over dinner, it's really quality, not quantity.
And asking how things are, ask the questions, right? Don't assume they're okay because things might be, you see things at home, things seem nice. And, we spoke with a lot of parents that, the things seem nice. I can't believe
Yeah.
He said he wanted to kill himself. You know, he said he wanted to not be here anymore. And I would have known. I'm talking myself into another conversation. I just want to say that in 9 out of 10 suicides, verbal information clues were given in advance, and parents, you're the least to find out. We as parents were the least to find out. We have to ask the questions we have to ask up front. We have to take the offensive and just ask how you're doing, what's going on.
Talking to a child about suicide doesn't make them commit suicide.
Nope.
And people worry about that. I don't want to bring it up because I don't want to put the idea in their head. If the idea is in their head, the idea is already in their head. And the more you listen to it doesn't have to be your child. The more an adult is there for a child, the more open that child's going to be. And so when there are things that are really bothering them, they're more likely to come to you because they know you will listen. So you want to keep that line of communication open. Sometimes the conversations they want to have with you may be uncomfortable, but but if you're able to hear it and listen to it, when those really bad things happen, they're going to come to you ahead of it, and you're going to be there to sort of work them through it. And so we don't get to the other place, right? It's just really important to make that quality time. Doesn't have to be quantity.
To be available, that's all. Doesn't cost anything. Exactly right. So here's the information. Next webinar is coming up November the 29th, and that is the kind of mentioned earlier, the art of setting limits, is the difference between consequences, punishments, rewards, and increasing parental patience. And we sometimes think as parents, is that even possible? No. So if you have questions, you can call me. If you have questions for Vicky, you can call me and we'll get that too, Ms. Reckenkamp, and then we'll go from there. But we really appreciate you taking the time. Vicky, I cannot thank you enough for helping me out with this. And I'll look forward to spending more time with you and doing these in the future with other topics that I know you're busy, that you have time for. But again, please listen to your children and talk with them and get to know them. And if you have any concerns, please reach out to us at school and we can follow up and work with you any way we can with some of the resources we have available in the schools that is confidential from the schools. So thank you guys. Thank you very much for participating, and you guys have a great one. And thanks so much.
Look at that. We did it.
Stop,